Very good evening. What a great evening today. So, there is some good news, amidst the pandemic. Okay, there is definitely with the lockdown set in for the past close to 3 weeks, 2 to 3 weeks at various states across India. There is some decrease in load on pulmonologists and other physicians' shoulder. So, amidst this very vital topic today, the mucormycosis during this COVID era, which we are, facing as an epidemic. So, in next 1.5 hours, the plan will be like this. Okay, first of all, I will introduce all our panelists. Following which, there's a 20-25 minutes talk on mucormycosis, and then followed by my dear participants. Okay, there will be interesting, Q&A session. Please post all your, vital questions, interesting clinical scenarios. Today, we will discuss in detail about all the various scenarios which we see in clinical practice. So first of all, I thank sincerely CCI for doing this saga of webinars back to back, and in particular Krishna Anna, okay, who is working relentlessly in doing this webinars, and what a wonderful enthusiasm and positive attitude he brings in CCI and across the pulmonologists in the country. And first of all, let me introduce myself. I'm Dr. Vijay Kumar, senior pulmonologist from Apollo Hospitals, Hyderabad, who will be moderating this wonderful session. And let me invite our senior most faculty today, Dr. BV Murali Mohan, sir, who is senior consultant pulmonologist and academic director, Department of Internal Medicine and Pulmonology, Narayana Hrudayalaya, Bengaluru. Thank you, sir. Please welcome. And next, coming to our young and dynamic pulmonologist who is budding in Hyderabad, nothing but our B. Viswesvaran, who is MD, DNB, DM, Pulmonary and Critical Care, is currently working as interventional pulmonologist at Yashoda Hospitals, Malakpet, Hyderabad. Welcome, Viswesvaran. And Dr. Mayank has sent a text message saying that he will be joining because a little late to the webinar. And meanwhile, Dr. Ravi Dosi, my brother, he is currently, working as a consultant pulmonologist and head of the Department of Respiratory Medicine at Indore, SAIMS. And he's currently CCI National General Secretary as well. We're honored to have you, Ravi, brother. Okay, looking forward for your inputs. Welcome. And the youngest among ourselves, Dr. Abhishek Tandon. Welcome. He's currently senior resident at Department of Pulmonary Medicine, All India Institute of Medical Sciences, Jodhpur. Welcome, one and all. So, Murli sir, any comments before let's go to the lecture, or you want to have any comments here? Please unmute yourself, sir.
Nothing at all. Nice introduction, and it's wonderful to be part of such a erudite panel. You spoke of questions. I've always learned the best thing is to pass it on to the youngest. They've read the most recent.
So let's start the lecture. Punit. Very good evening. So, now, thank you once again, Krishnana, for bringing out a wonderful topic, which is a need of our, which needs a lot of knowledge dissemination, which was hitherto rare. To be frank, okay, it was so rare that we at tertiary care centers probably used to treat 3 or 4 mucors in an annum, whereas now we don't believe. Okay, at least uh, my hospital at Apollo Jubilee Hills, where I practice, okay, we are seeing at least 3-4 cases daily. So next 15 to 20 minutes, okay, I will be running through the essential things what we need to know about mucormycosis, that is COVID associated mucormycosis, the black fungus. It is a life-threatening infection caused by fungi of the order of mucorales, and incidence definitely it is on rise. Okay, we all know that. For decades, what is important is, okay, for the past 4 decades, the mortalities have not been have been consistently more than 40% across the various institutes, across the various case studies and case reports as well. So the maximum amount of mortality what we see in 60 to 90% in hematological malignancy. On the other hand, okay, in the current panel discussion, we will discuss about what is the mortality that we are seeing in our hospitals. And in COVID era, yes, obviously in the second wave, the incidence and fatality have been drastically increased. The incidence is definitely more than first wave, whereas fatality we have to see the other factors as well. We will discuss. There has been exponential increase in incidence in India when compared to first wave. The second wave, we are seeing tons and tons of cases. Yes, public, they know very well about mucormycosis. There is enough amount of debates, enough amount of patient information literature that has been published in various news articles along the print media, and then and the television shows, news debates. So hitherto, India contributes to 40% of the global burden of mucormycosis, with an estimated prevalence of 140 cases per million population, and the single most risk factor for development of invasive mucormycosis up till this COVID onset is uncontrolled diabetes. Studies have revealed that 47% of Indians are unaware of their diabetic status, and only a quarter of diagnosed cases have achieved adequate glycemic control. And this brings me an analogy where water everywhere, not any drop of water to drink. This was said by Samuel Taylor. Similar to that, okay, black fungus and fungus everywhere, but there's hardly any antifungal to manage as of today in India. Very, very few of the patients are getting the antifungal medications, and then among the few of the prescriptions, okay, suboptimal doses are being delivered, and then probably these fungi may develop some amount of antifungal resistance in future. We never know. Only time has to tell. So, what does this picture reminds you? See, so we have to have a very strong clinical suspicion. Even if everything is normal clinically, take a deep breath. Calm and compose. Being a clinician, okay, despite the pandemic, you have to keep yourself calm and composed. And then a subtle hint like a streaky hemoptysis, new onset of sinus symptoms, new onset of headache, new onset of visual disturbances. Please do not, please do suspect that there may be, hidden black fungus lying there. So, mode of spread of Mucor is by inhalation or inoculation of the sporangiospores in the skin or mucosa, and obviously Mucormycosis is a ubiquitous organism. Some studies found seasonal incidents where in autumn, the cases will be more. In developed country like West, the Mucor used to occur in only in immunocompromised hosts, but whereas before the onset of the pandemic in India and Southeast Asian countries, uncontrolled diabetes and trauma are the key reasons for mucormycosis cases. The pathophysiology is inhaled sporangiospores reach the respiratory tract, and then they reach the distal alveolar space, and then from there the fungi lodge there, proliferate there, and then via bloodstream they disseminate into various other organs. So in the current scenario of COVID-19, along with there is clear-cut evidence that there's a lot of immunological changes that occur with COVID-19, and presence of diabetes or steroid-induced diabetes, and in presence of steroids, it can lead to hyperglycemia and various inflammatory marker elevation and lead to increased incidence of mucormycosis. Various iron formulations in combination with zinc have been consumed by patient populations, without any prescriptions. This leads to increased reticular activation, reticular system activation, increased intracellular iron, and increased ferritin. Ultimately, more amount of sugar levels, which might lead to mucormycosis and which might precipitate diabetic ketoacidosis as well. So, what are the various types of mucormycosis? Rhinocerebral, pulmonary, cutaneous, disseminated, gastrointestinal, and various other variants like endocarditis, osteomyelitis, peritonitis, and renal infection. So looking at the incidence burden, rhinocerebral accounts for almost 40% of cases, whereas pulmonary accounts for almost quarter of cases. Various other predisposing factors other than COVID are hematopoietic stem cell transplant, neutropenia, malignancy, diabetes with or without ketoacidosis, iron overload, major trauma, prolonged use of corticosteroids, intravenous drug abuse, and malnourishment. Coming to pulmonary mucormycosis, in patients with neutropenia seen on patient with induction chemotherapy, hematopoietic stem cell transplant, GVHD, and generally neglected, the mortality may reach 76%. And the common presentations which we discuss in the coming slides. So the lung CT of these patients when to suspect mucormycosis. In these patients, when suspected, CAT scans may reveal a cavity and a reverse halo sign, multiple nodules, and pleural effusion. Presence of reverse halo sign, which is atoll sign, more than 10 pulmonary nodules, and pleural effusion is more in favor of COVID-associated mucormycosis than COVID-associated pulmonary aspergillosis. Presence of bronchial thickening, tracheobronchial involvement, peribronchial collection, and tree in bud nodules are more in favor of COVID-associated pulmonary aspergillosis. Tuberculosis being quite endemic, we have to rule out in presence of tuberculosis in all of these cases, which may mimic, radiologically invasive fungal infection. Coming to rhinoorbital mucor, most common type of, mucormycosis, particularly in diabetes and also in, COVID-associated mucormycosis. In pathogenesis is, the same, which we have discussed. These, rhinooptal, mucormycosis cases can lead to, cerebral vascular invasion, thereby, dissemination. The fungus invades the cranium through orbital apex or cribriform plate of, ethmoid bone, and ultimately becomes the cause of mortality. Initial symptoms are consistent with those of sinusitis and periorbital cellulitis and includes eye or facial pain and facial numbness, followed by blurring of vision. Various warning signs and symptoms of rhinooptal cerebral mucormycosis, nasal stuffiness, foul smell, epistaxis, nasal discharge, nasal mucosal erythema, eyelid, periocular and facial edema, and eyelid, periocular and facial discoloration, regional pain, facial pain, worsening headaches, proptosis, sudden loss of vision, facial paresthesia, anesthesia, sudden ptosis, ocular motility restriction, diplopia, facial palsy, and others like fever, altered sensorium, paralysis, and focal seizures. Yes, fever is variable, and typically the total counts will be very high. Preoperatively, CECT is, contrast enhanced CAT scan, and if required, MRI are very, very vital in diagnosing the extent of the disease. Yes, most of the mucormycosis cases, by the time they present, they will be a disseminated ones because, easily this fungus is by nature, it is an angio-invasive fungus which spreads simultaneously to other organs. And coming to diagnosis, rhinooptocellular cerebral, consult an ENT surgeon from endoscopic, for endoscopic collection of debrided tissue or biopsy. And normally we must, send in saline and as well formalin-based sample. So saline for microbiological processing and formalin for histopathological evaluation. And coming to our pulmonary cases, so generally, at least endobronchial biopsy or lavage, mini ball, and sometimes, CT guided biopsy may be beneficial. So diagnosis confirmed by fungal staining or culture from appropriately collected specimens. Yes, mucormycosis is a medical emergency, and in current context should be started on empirical therapy even prior to the moment you suspect. You have to start antifungals. Suspected patients should undergo appropriate, imaging studies at the earliest. Coming to rhinooptal mucormycosis, MRI of orbit and cranium is very, very essential, and to rule out pulmonary mucormycosis or extent of pulmonary mucormycosis, contrast enhanced CT, okay, or plain CT is recommended. We've discussed this and how to prevent, this mucormycosis. Remember, apart from regular things, a good glycemic control is very, very essential in controlling the or prevention of mucormycosis. Systemic steroids, when not indicated, should not be administered. When there is no hypoxia, do not give systemic steroids. And oral steroids are contraindicated when there is normal oxygen saturations on room air. If systemic steroid is used, invariably, even if the patient is not not a diabetic, make sure that you monitor his blood sugar levels. And duration of systemic steroids or oral steroids limit as per evidence. Okay, the maximum that we can give is 5 to 10 days. So universal masking, reduce exposure to mucorales, and avoidance of construction sites is very, very essential in prevention. During discharge of the patient, make sure that you counsel the patients so that the chance of any symptoms like facial pain, nasal blockage, or sinus symptoms, or loosening of teeth, and respiratory insufficiency, chest pain, and fever. So all these symptoms, they have to bring it to clinician notice so as to diagnose the mucor very early and treat appropriately. So as discussed, early diagnosis is always key. The later the diagnosis, the mortality goes up. Surgical management plays a very, very essential role in at least, rhinoorbital mucormycosis. We'll discuss in the panel discussion about this flow chart. What are the various antifungal treatments available? So polyenes are primary antifungals, which includes conventional amphotericin B and liposomal amphotericin B, posaconazole and isavuconazole. So yes, we discuss treatment of COVID-associated mucormycosis, a team approach, and then the multidisciplinary teams generally includes physicians or pulmonologists or ID specialists, along with microbiologists, histopathologists, intensivists, ENT specialists, head and neck surgeons, and ophthalmologists and radiologists. So control of diabetes and DKA is very, very essential. When steroids are not indicated, abruptly stop steroids and discontinue other immunomodulatory agents like baricitinib and tofacitinib. Surgical debridement plays a very crucial role in management of rhinoorbital mucormycosis. And what is its role in pulmonary mucormycosis, we will discuss in upcoming case scenarios. So we discuss when the patients are, medical treatment on antifungal therapy, it's very important to monitor their renal functions and electrolyte levels. It's common to, see rise in creatinine levels or onset of acute kidney injury, along with, electrolyte disturbances like hypomagnesemia, hypopotassiemia, and hyponatremias. And just quickly, next 5 minutes, I will share, 3 case scenarios. This is about a 72-year male with severe COVID who was non-diabetic but became diabetic with steroids. And in this patient, remdesivir and convalescent plasma was given. Dosi was not administered. And at the time of shifting to ICU, we have done a CT, which did reveal the right upper lobe nodule. And this patient, was just stabilized, and from all various, high-end modalities like high-end non-invasive ventilation and HFNC. And suddenly, when he was in room, he started throwing a streaky blood in the sputum. So this made us to, take him for a CT scan or PET CT scan, and which revealed right upper lobe nodule, which immediately we have biopsied this by CT guided biopsy, which revealed, mucormycosis. Before having a conclusion, confirmatory diagnosis, we have started him with liposomal amphotericin B. This was in first wave. We have a luxury of using, liposomal amphotericin B because of availability in the first wave. So tissue diagnosis did confirm broad non-septate fungal hyphae with morphology suggestive of mucormycosis. So along with liposomal amphotericin B, posaconazole was added as a combination therapy. So in due course, while we have started the patient on combination therapy, patient landed in acute breathing difficulty, and we thought Mucor is worsening, but we have did repeated CT. And the nodule size has decreased within 10 days to at least 4-5 mm decrease in size of the nodule and the right upper lobe. Whereas there is a new onset of infiltrates in the left upper lobe, and this made us to think of persistent post-COVID inflammation, which is manifesting as increase in chest tightness and increase in oxygen requirements in this patient. Then we have administered Solumedrol carefully with controlled monitoring of sugars. So patient became patient improved clinically and weaned off from oxygen support. And later on in due course, patient developed fevers again. And when we evaluated, it was PICC line associated Klebsiella growth. Then we have removed the PICC line and then treated the Klebsiella with the appropriate gram-negative antibiotics. So throughout the course of treatment, underlying diabetes has been managed effectively. Repeat PET-CT was offered, and 6 weeks liposomal amphotericin was given and then stopped. Then rest of the course of the illness we have managed with oral posaconazole therapy. So at 6 weeks, the nodule size have decreased by more than 50%, and later now patient comes for OPD follow-up once in 3 months. He is doing absolutely brilliant. And looking at the overall survival rates of patients with mucormycosis, approximately 50%. Although in the recent publications we do see survival rates have gone up. 85% have gone up in the recent reports, because we are more well versed with the management of mucormycosis. In contrast, remember, pulmonary mucormycosis has a higher mortality, that is around 65% at 1 year, because it is very difficult to diagnose. Looking at this case scenario, if you can identify this case at a nodule level, then we can definitely treat it even without the help of a surgery. And look at this case where patient was came with uncontrolled diabetes, hypertension, coronary artery disease history, came to OPD with complaints of fever and cough, streaky hemoptysis and shortness of breath. And quickly going through the X-ray, there is a left-sided some amount of pleural effusion, CP angle blunting, and then retrocardiac. There is some opacity and the cavity in the left lower zone. So he was in elevated renal parameters and hyperkalemia, for which hemodialysis was offered, and we did evaluate it. CT did reveal patchy parenchymal opacity with few areas of cystic changes and air bronchogram in superior and inferior lingular segments, and vague GGOs in lower lobe and medial basal segments of right lower lobe, atelectatic bands in the basal segments of left lower lobe, along with the left loculated pleural collection. And subsequent CT did reveal, there is further, necrotization happening in the left lower lobe. So this patient, we offered, bronchoscopy diagnosis. As soon as, we see this and uncontrolled diabetes, we have started him on, amphotericin B, liposomal, and then ball cultures did reveal, mucormycosis, and the sputum did reveal, Klebsiella, and we have done, endobronchial biopsy from this, whitish thing, which is, there in left lower lobe and lingula, and then the biopsy turned to be, there is no evidence of invasion into the tissue, but there is an element of, fungal elements with broad septate hyphae, which is suggestive of mucormycosis. So with this evidence, we started treated for 4 to 5 days, and we started treating with cephalosporin sulbactam and then atypical coverage clarithromycin in the beginning, but subsequently we added amphotericin B after seeing the CT scan, and posaconazole have also been added as soon as we see the report of fungal elements in the ball. We have added posaconazole as well. So after stabilization, we thought of taking for lobectomy or pneumonectomy. So looking at the healthy tissue, so the patient was offered, the surgeon has offered a wedge resection, and following which 2 to 3 days down the lane, patient landed further aggressive spread of fungus to the rest of the lung, and we lost this patient. And so the point here, what I'm stressing is, so mucormycosis spreads very, very aggressively. So make sure that we identify at early stage. Once there is necrotization, gross necrotization occurs, and it crosses fissure, it enters into the pleural space and presents as empyema. It is already an advanced disease. very unlikely that we will, get a cure from mucormycosis. So, last case, 30-year-old female post-renal transplant for nephrotic syndrome, and we have diagnosed this. She was offered, with moderate hypoxia, 40 mg of, Solimedrol twice daily was offered, and for 4 to 5 days, and then we stopped Solimedrol because she was complaining of sinus symptoms, and CT findings was suggestive of invasive fungal sinusitis. Fessant debridement was done, and she is getting recovered now. Patient is now being managed with posaconazole. So with this, and what is that, we may be looking at the brighter side. It's for all pulmonologists, unique opportunity to learn and treat mucormycosis. Please make sure that we start antifungals and aggressive management of these cases. Hit hard and hit fast rule. Looking forward to learn management of patients in the current existing challenging scenarios. We will discuss in the panel discussion. Discipline our team of physicians, intensivists and pulmonologists to recheck their checklist of steroid use, restrict unnecessary antibiotic use, and adhere to strict glycemic control, which is very, very crucial in management and prevention of mucormycosis. Train rapidly. So my urge here, to our chairman trustee, Dr. N.H. Krishna, that why can't we develop from CCI? Train rapidly as many pulmonologists across the subcontinent and hospital teams on a short-term basis. Maybe we can design, CCI can design a 3-hour training module session under the able guidance of Dr. N.H. Krishna and Murali Mohan sir, Chabra sir, and other seniors. And why can't we run? Because it is need of the hour. With this, I would like to go ahead and then start the panel discussion. Thank you. Yeah, hi. Welcome, Mayank. We were missing you, right?
Yeah, I'm back here, sir.
Yeah, hi. Right. Hope the case got stabilized.
Yes, sir. These days, it's crazy. Anytime calls are there.
Yes.
Yes, sir.
We are always on our toes.
Yes, sir.
So let me come back to the questions. Sir, may I request this question goes to Dr. Murali Mohan sir. Why COVID patients were more susceptible for mucor infection? Why India has become the mucormycosis capital in the world?
Let me answer the second question first. I think we've always been the mucormycosis capital of the world. We've always had more mucor than other countries, possibly because of our climate. It cannot be the only answer, but we should remember that we are the diabetes capital of the world. We are a warm, generally humid climate, at least in parts of the year, ideal conditions for fungus to grow. We've all seen fungus on the walls of houses, including my own house. I can show you a zoo of fungi growing on my back wall. So it's not surprising that we have a lot of mucor in general compared to other countries. I think what has really changed in COVID-19 and why we are seeing so much more mucor now, to abbreviate it, like you said, as CAM, why we are seeing so much CAM now, I think everybody has a theory and no theory is by itself right. I think this is a multifactorial thing. It can never be a single factor. You'll hear people telling you that steroids are important, but you'll also hear that people who never received steroids have had mucormycosis. You will hear that, patients who are immunosuppressed in some way are the ones who get mucormycosis, other than steroids, whether it's tocilizumab or itolizumab or one of the NIBs, baricitinib. But we know people who've never had any of those who come with this. So I think it's multifactorial. And if I have to list out some of these conditions, I'd say, first of all, there is a good correlation between what the coronavirus does and what the Mucor does. And we must remember that even in SARS, you had a big problem with Mucor. SARS-1 I'm talking about, not SARS-2, where almost 26% of patients were described as having Mucor, and a large number of deaths occurred in people who had Mucor. And in fact, one of the commonest causes of death in SARS was an associated fungal infection, typically Mucor. So there seems to be some correlation between coronavirus and Mucor. Both do one thing. Both latch on, they enter the respiratory tract, as you clearly showed in your lecture. They enter through the upper airway. Very little goes through the gut really, and then spreads into both the upper and the lower airway. Once they enter, they latch on to receptors, different receptors. But after that, both of them tend to be angioinvasive. They both produce local thrombosis and tissue damage. So it's not surprising that they work together. They work more effectively. And when COVID has already damaged the mucosa, obviously Mucor will find it easier to enter and to become more angioinvasive. And of course, there are other theories. And I think this is important, the iron content of the tissues. We learned very early in the COVID pandemic that there is heme involved, heme stripped off from hemoglobin, iron stripped off from heme. So you have very high free iron levels. The body compensates by ferritin mopping up this and increasing ferritin levels, which have always correlated pretty well with outcomes in COVID. So, and we know that Mucor is very heavily iron avid. And if you feed Mucor with iron, then it goes out of control. There may also be a role for zinc. We've all enthusiastically been using zinc. And one of the first things I did after the second wave started and we saw a lot of Mucor is try and withdraw the zinc quickly, which we were giving without evidence for benefit earlier. So a lot of things why there is a correlation and why...
You suggest then that particularly when we are dealing with, high-risk people, COVID patients, do you suggest not to replace them with, zinc?
Yes. In fact, I have now started giving it for 1 week in the beginning during the mild phase and then withdrawing it. I don't continue it for a month like I used to do earlier.
Right. Right, sir. So thank you, sir. And coming to Abhishek, are you there?
Yes, sir.
Hi. In your experience, what do you see, what are the common presenting symptoms of mucormycosis? When do you suspect these patients?
Sir, the symptoms of mucormycosis, in my experience, would depend upon the site that the mucormycosis has infected. So the most common type would be a rhino or bitocerebellar type, where the patients could present with a discoloration of the cheekbone, loosening of the teeth, a blackish or a brownish discharge from the nasal cavity, swelling of the eyeball, or a severe headache, loss of sensation of one side of the face, and the second most common type being...
These are all very advanced stage. In your clinical practice, do you find some clues that, you can pick these cases slightly at an earlier stage? Because it is being proven that if you can identify the presence of fungus in first 5 days, the mortality rates, if you start treatment in first 5 days, the mortality rates will be, we can decrease the mortality rates. And morbidity out of, the surgery will also be much better. Please, go ahead.
Yes, sir. So in a post-COVID patient or in any patient who is susceptible to develop an opportunistic infection, in this case of mucormycosis, the early symptoms could just be a pain in one side of the face or loss of sensation of one side of the face. And when these patients present to us, it's very important that we keep a very high degree of suspicion and go in for a diagnosis pretty early. Like you correctly pointed out, that early diagnosis is the key. And as soon as we start the treatment in them, the earlier the better. And any delay in starting the life-saving medicines like amphotericin B could be a detrimental cause over here.
Yeah. And in pulmonary mucormycosis, I'll come to Mayank. One moment.
Yeah, sure.
In pulmonary mucormycosis?
So in case of a pulmonary mucormycosis, the common symptoms that I have seen would be a very high-grade fever, a patient presenting with cough with expectoration, which could be blood-tinged, or chest pain. So these are the certain common symptoms that I have seen in my practice, sir.
Thank you. Mayank, please.
So, interestingly, in some of my patients, I would like to share what symptoms they had and how I picked up them, you can say early or late, whatever. But very interestingly, some patient, like one of the patient relative started saying, I am not receiving update from my patient. He's not using mobile phone. He's not using WhatsApp. So then I asked him, why are you not using WhatsApp? He said, I am having a blurring of vision. I am not able to see properly that I used to see again. So that level of suspicion, then I examined and I got the CTPNS and all this nasal scrapings done. They come positive for so these diseases run so silent.
Right.
So silent that you may not be able to pick up if you're not having a high index of suspicion. One of the patient on one day round had a ptosis, unexplained ptosis. Then it was not a very not a very strong, like she was able to open, but the ptosis was finding that was there. Examined it. That patient turned out to be Mucor positive. Then another group of patients, as we are using high flow of oxygen these days, and there's a lot of nasal crustings that happens.
Yep.
The patient has a very dry mucosa, nose, and these all. So I always, those on high flows or on receiving steroids or on a diabetic status. Now I'm in a practice to routinely get them examined from the nasal ENT department. At least get a check of a nasal nasal endoscopy, or crysting secretions can be sent for the fungal examination so that it can be picked up early. If we pick up in an earlier phase, like before the sinusitis or like in the sign, but if it has reached beyond the necrosis has started, or the delay will be carrying a very high level of mortality. So index of suspicion should be high.
Thank you, Mayank. So, hi Vishwesh.
Hi sir.
How do you diagnose mucormycosis in a COVID patient? Okay. Both in acute phase on post-COVID scenarios. So, what is the state of art to diagnose these patients?
So, to be very honest, like this mucormycosis is ubiquitous. So, even if you get positive microbiology for mucormycosis, sometimes it may be a contaminant as well. So, the absolute strong point to say that it is a invasive form of mucormycosis is just by histopathology. Like you take a biopsy, you demonstrate a broad aseptate hyphae in the tissue, that is with along evidence of angio invasion, then that is a classical. But unfortunately, like most of the times, be it a pulmonary sample or in the early stages of your orbitocerebral, you might not have an access to it. So the most clinching point, what we have to understand is the clinical background. So if you have a patient with an immunocompromised state, like a diabetes or post-renal transplant or hematological malignancy, and right now, for that matter, any part of any sort of a COVID patient, and along with that, you have a classical symptom that might suggest a particular organ involvement, like a nasal stuffiness or blurring of vision or a facial pain, or as proptosis, or you have a patient having high-grade unexplained fever with hemopsis and chest pain. Along with that, you are able to demonstrate mucor. Then it becomes a criteria for a possible or a probable mucormycosis, and that warrants a treatment. Apart from that, there are certain things like the KOH mount you can do and demonstrate a mucor. Then you can have the samples, respiratory samples for cultures. Right now, what we are relying upon more in the clinical practice is the Mucor PCR, because that might pick up much earlier than what we get through other modalities. But having said that, in fact, even in the Western countries, most of these mucormycosis are identified on the postmortem through CT-guided biopsies. So yes, that is the only definitive way we can say it's a mucormycosis. But given the scenario and given the amount of cases we have and in the pandemic where we are in, even a culture, even a microscopy sample suggestive of mucor in an appropriate clinical background should be treated for mucormycosis pending biopsy evaluation.
Yeah, thank you, Vishwesh. Over to Murali sir. Sir, as Viswesvaran said, it is a ubiquitous organism. So, do you think, presence of mucormycosis on a smear of any secretions like, ball or something, if there is no other signs, can we consider still this as a commensal, or definitely, it says that it's an invasive fungal infection? What is your take on it?
As Dr. Viswesvaran rightly said, it's based on the clinical features. It's only then that you can really accept that this is a cause. Because, this is a saprophyte. It grows just everywhere. It's not surprising that you get it on surfaces. If you get it in places where you don't expect to see it, for example, you're doing a bowel sample and you get it, just raises the index of suspicion a little more. If that is associated with the clinical features, then I think I would, elevate that to a very high level. The point Dr. Mayank was making, you might find it encrusting in the nose when it's very dry. That doesn't automatically mean that this person is infected. But if the same person had headache, nasal strain, bloody secretions, I would start to get a little more suspicious. Okay, in the appropriate setting, which again, I think both the speakers have said very, very clearly. So, in short, it raises the suspicion, doesn't prove it. Histopathology is the gold standard. You have to demonstrate tissue invasion or angio invasion. Apart from that, the problem with PCR, again, that Dr. Viswesvaran mentioned, it's highly sensitive, but can hardly be specific. It's a little too sensitive. That's the whole problem we always face with PCR. So a PCR
cost effective as well, on the other hand.
Doesn't really support the diagnosis. So it is a clinical diagnosis still.
Right. Thank you, sir. Ravi Bhai. Dr. Ravi Dosi.
Yes, sir.
Yeah, hi.
Hi.
Welcome. You were hidden, man. Right. So, in a limited setup, because, whatever said and done, every hospital or, every small units may not have, nasal endoscopy or bronchoscopic biopsy, ball, cryolung biopsy, all these things. One may not have it. But in a limited setup, what do you suggest? Okay, what's a quick way to diagnose mucor?
Well, the quickest way would be to, first of all, in a specific clinical setting, you need to have a clinical setting, a clinical mindset, and something propagating you to that diagnosis. You can take simple things, simple nasal scraping. You can go in for simple imaging like CT. See, you don't get MRI everywhere, but CT is still having a very widespread reach. So I think these are few things which we can do at even very basic centers nowadays, and definitely as the scale of radiological imaging is improving, we are even able to get MRIs done at very remote places nowadays. But I would prefer at least a nasal scraping and a CT scan to be the bare minimum for having a clinical suspicion, for having a diagnosis of mucormycosis. Right. Without that, it is difficult.
Thank you, Ravi Bhai, for your inputs.
So one more thing for the nasal scrapings that we saw, like if it is coming with the signs of mucor, with a microscopic positive mucor, but there is no clinical sign, we can also utilize beta-3 1D-glucan for assessment of if any invasion or any The only patient is not fit for biopsy. And
corporate sectors do have it, but not in the two-tier cities. There is beta-2 glucan is not available. Okay,
so separate hyphae on KOH mounts. That still is a thing. It is a novelty still in basic labs.
True, I totally agree. Right.
You've also got to be a little careful when you do any of these tests like glucan and galactomannan, because there are a lot of false positives associated also with the drugs that you use for the patient.
Yes, sir.
So you've got to be a little careful. Again, it always comes back to what is the background risk.
Yes, sir. Even usage of piperacin, tazobactam, other cephalosporins can give rise to false positive report. Right. So, Mayank,
Yes, sir.
is there any reason why rhinocerebral mucormycosis incidence is higher than pulmonary mucormycosis?
So interestingly, I was also thinking the same. Why we are not seeing, despite so much bad lungs, we are not seeing pulmonary mucormycosis, but it is coming up with the head and neck cases. So I looked up several articles also, but could not find the exact reasonability for this. But what I feel that it is like the spores, as we say, are ubiquitous in the respiratory tract. They are often they are phagocytized and they are destroyed by our immune cells basically. And in COVID inflammatory phase per se, what is happening? The inflammation is already upgraded. The pulmonary inflammation is already in a very upgraded state. The phagocytosis, everything is happening. So what I feel, the nasal part may be spared. The nasal part may not be having so much of immune reaction, and with the use of immunosuppressants or local factors or per se environmental factors, the sporulation and the presence of mucor in the nasal tract, it may cause a further invasion of the mucosa. So heightened inflammatory response in the lung can be one possible explanation for that.
But there is no scientific basis for this, right? So,
can I ask provocatively, are we missing pulmonary mucormycosis? Because you don't get the classic findings that you'll see in somebody without, all the damage that COVID-19 does. Is it possible that we are missing some of it, and that explains some of the patients who are getting rapidly worse and dying?
Maybe
can be a possibility, sir, because even in the we are not getting so much of sputum examinations done in the some of resource limited settings because of the lack of biosafety cabinets and all. But yes, that can be the factor.
But on the other hand, most of the sick patients, whom we cannot able to even we cannot take them for CAT scans to look for what is CT findings. Is there any evidence of because once a patient requires a high FiO2 of beyond 60%, it's very difficult for them to take a CAT scan and then get the CAT scan done. Viswesvaran, you want to add something?
That's a very beautiful statement from the group on Aspergillus. They say that most of these radiological presentations of these fungal infections are mimicked by our COVID. Let's say, for example, GGOs. Let's say, for example, reverse halo. Everything except for cavitation and pleural effusion are mimicked by your COVID. So differentiating a pure COVID from a COVID with a coexistent fungal infection becomes very, very difficult in terms of radiological aspect. Until and unless you have a perfectly fitting cavity or a pleural effusion, which can be the pointers towards an alternate diagnosis. Most of the time, we assume it to be an exacerbation of or a worsening of an underlying COVID infection with a hyperinflammatory state, and we keep boosting these patients with steroids without any outcome. So that is one of the disadvantages we have. And but the point of contention again is, are we going to sample all these patients for fungus? That is also not a possibility. So
not a possibility, Viswesvaran. Just and again, so as you gone through the first case scenario, the presence of such a beautiful nodule, we can identify.
Exactly.
A centimeter nodule, we can identify, and then we can biopsy those things. So we should be very, very aggressive, keep a very low threshold to differentiate what are the findings, and then differentiate from the just regular COVID and from associated.
But the problem is that differentiation is very, very limited because your reverse halo, your ground glass opacities, everything mimics an exacerbation of your underlying COVID. So maybe most of these fungal infections in the Western data are also diagnosed only postmortem, like, to be very honest. So despite having a very high clinical suspicion, probably we are bound to miss few cases of coexistent fungal. And that is when probably there might be a role of an empirical antifungal, which is still not in the guidelines, when your clinical suspicion becomes very, very high.
Yes, agree with you. Right. Abhishek, hi. So here comes a question for you. What are the risk factors for causing mucormycosis in COVID-19? Yes, we have discussed. May I have your inputs in very short?
So, like Dr. Murali Mohan beautifully has already elaborated on all the points. Just one more point that I wanted to add, apart from that, is that severe COVID-19 pneumonia, by virtue of its lymphopenia, predisposes the host itself to the development of a lot of opportunistic infections, and I think Mucor is one of them. And secondly, like Sir rightly pointed out, we are the diabetic capital of the world. But apart from having so many people who are diabetic, we have, I guess, a larger number of people who are diabetic but undiagnosed. And to treat a patient population of that magnitude with an injudicious and an indiscriminate use of high doses and long acting of steroids, especially early in the course of the illness, it's been a complete catastrophe, sir. When they present to us at our center, their sugars are in the 300s, early 400s. And at that particular state, I guess Mucor is just lurking down there and just waiting to attack. And apart from that, the things like Sir pointed out, zinc, iron, and also since the very beginning, we have seen antibiotics with no proven antiviral capacities like azithromycin and doxycycline on the prescription of almost every practitioner, sir. And I guess it has a role to play when it disrupts your local microbiota of the lung and in that particular way enhances the growth of a Mucor infection, sir. And all the other points like sir.
Brilliant inputs. So, Sir Murali Mohan, sir, do you think, there's there is a huge difference between, incidence of Mucor from first wave and second wave. Do you think, is there any strain variant which is causing more amount of COVID associated mucormycosis, or it's purely inappropriate use of steroids?
I think it's a little bit of both. I think the strains are definitely changing. The speed of spread between the first wave and the second wave, huge difference. We've reached a peak much faster. We're seeing a lot more rapid progression. First wave, we were comfortable until day 7. And between day 7 and day 10, we started to see the hyperinflammatory problems. Now we are starting to see it around day 5 itself. So this is clearly a more aggressive form in many cases. We are also seeing the other way. We're seeing very mild disease. So we're seeing different strains producing different problems. At the same time, I think in the first wave, steroids came in later. The recognition after the recovery trial that dexamethasone was useful came in later. So steroid use was not quite as widespread the first time. This time, people are starting it on day 1, as soon as a diagnosis is made. Sometimes even before the diagnosis is made. Not nobody, but a lot of people are not following the guidelines strictly. And I'm worried about that. I think we are contributing partly, the virus is contributing partly.
Yes. So religious recommendation of steroids and usage of steroids is very, very important in controlling this, epidemic of mucormycosis. Viswesvaran,
one more thing I have observed in this strain, particularly the relapse under longer duration, which is exposing the patients to a longer duration of steroids. Like the relapse, it happens even after 10th day, 11th day, patient is moving fine. But again, this, as we said, maybe any superimposed infection or what, like CRP again goes back to higher state, the patient again worsen. Then we again step up the steroid. So the duration, ultimately, the duration also matters apart from the steroids usage. Also, the diabetes control, I am seeing the bulk is there. So there's also a little worried about the diabetes. So every time I see, and I myself are seeing the charts regularly, I come across patients who are having a high sugar levels. So these two things, the duration and the diabetes control, these things also should be watched for the things.
So cumulative dose of steroids is very, very important. And management of strict glycemic control has a potential role to prevent further new cases, and avoidance of doxycycline, azithrol usage may have some beneficial role. Viswesvaran, anything you would like to add here?
Nothing, sir. Only most of it has been covered. But one point, what I want to extra, I feel like probably the second wave is exposing us to more mucor is because of the increase in the length of the stay, we are moving from managing an acute illness to a more chronic illness where we forget about the nutritional aspect at all. Like we don't look into the patient nutritional aspect given the pandemic. So malnutrition is one of the major risk factors for even these mucormycosis. So since we don't give importance to nutritional aspect, we don't know whether that is suppressing the immunity and exposing these patients to higher incidence of mucormycosis, especially on a patient who is in the long-term setting in the hospital. And second thing is there is a chronic persistent inflammatory aspect of this virus in comparison to what we saw in the first wave. Most of the patients become cripples with requiring high support of oxygen. They stay in the hospital for a longer period. And as rightly pointed out, as long as the patient remains in the ICU, they continue to remain on some sort of an antibiotic, some sort of at least a low dose steroids. All this becomes a potential factors for exposing them to a higher incidence of mucormycosis. So I think nutritional aspect, especially in a long-term patients, should be given a due concern because most of us neglect because we are busy in managing the acute and we tend to forget that probably we are dealing with the long COVID patients who are more prone to these fungal infections.
You added a brilliant point, Viswesvaran. Okay, really I agree with you. Yes, management of sugar, strict glycemic control, okay, cumulative dosage of steroids, we have to keep an eye on it. And then whenever it is unnecessary, please, abruptly, take a, tapering dose of steroids and then stop it. And diabetes management, and then you brought in a very good point of nutrition in probably, plays a major role in incidence of mucormycosis. So,
can I just ask an answer? I don't know why it's more common in diabetic ketoacidosis than hyperosmolar glycemic disease. Mucormycosis has been linked with decay. It's not so much other things. Is there something specific? Is the acidosis got something to do with it?
Maybe. Yeah. Anyone wants to add here?
Dr. Viswesvaran, Dr. Abhishek.
I think it's the same thing, sir, that ferritin complex in an acidemic state, probably the virus, I'm not very sure, I need to go back to my basics, but I think that might be the ferritin again, that might be the role.
Exactly. So the acidosis part of the decay, it predisposes a hyper iron state in the body, and as the increased iron state is already a predisposing factor for the fungus to sort of latch on and enter to the cell. So that becomes a very important point to facilitate an increased incidence of a mucormycosis in a decay as compared to a hyperosmolar state. Sir.
Thank you.
Thank you. One size of shoe does not fit all. Yes, management of mucormycosis is a precision medicine. Early debridement is really useful in mucormycosis. How does the role of surgery differs in each variant of mucormycosis? Question to Viswesvaran.
Actually, the management of mucormycosis is, first what we have to realize is it's multifactorial. Your drugs alone are not going to act. The first and the foremost thing is what predisposes you change it. Like, for example, you are putting these patients on immunosuppressants or tocilizumabs, baricitinibs, or leukopenia. You need to reverse all these causes. Second thing is strict glycemic control. And third important arm of your treatment strategy still remains early debridement. So it differs from site to site. For example, when you have an orbitose-rhinocerebral form of mucormycosis, you will go for early debridement when you feel that the brain invasion is not that significant that it will not alter your outcome. And your FES is always preferred over an extensive debulking, like in the form of a maxillary removal or an orbital decompression or something like that. So FES is always favored over an open surgical technique with respect to the orbitorhinocerebral. When it comes to the lung, the issue what commonly happens is we are always in a dilemma whether we have to straight away go for a lobectomy or not. So one important aspect when we really need to consider lobectomy is when you have a patient who is having hemopsis. because that is the point where this mucor is causing an angio invasion and there is an impending cause of a massive hemoptysis and the patient may bleed to death. So if you have a patient of a mucormycosis having a lesion in the lung and showing signs of angio invasion with infarction and bleeding, yes, that is the point you need to seriously take into consideration the lobectomies or the wedge resection of the mucormycosis. But if you have a very, very small isolated nodule, very early stages, then still you can wait and look for response to your medical management. So apart from that, if you have a very extensive cavity, automatically it becomes a candidate for surgical resection. But one point to consider is when we are dealing with the COVID, most of these patients are on ventilator associated with other factors like thrombocytopenia and poor general condition, which makes them non-candidates for any extensive surgeries pertaining to the lung, though they are able to do these ENT surgeries. So that is one difficult scenario we are facing. But even then, if you have a impending massive hemoptysis or a huge cavity, then your drug penetration into those cavities will not be good. So you need to go for early surgical management. But surgery is not indicated in all patients. You need to take into consideration the patient aspect like thrombocytopenia, overall general condition, and whether your surgery is going to cause more benefit or harm. That balance should be always taken into consideration.
Ravi bhai,
Sir,
would you like to add anything, to here to this question?
sir, basically surgery, I would say is the primary management along with the multi-modal nature of
Approach, right.
But again, like there are several case scenarios like Viswesvaran pointed out where surgery is not feasible, like the patient being on ventilator, extremely immunosuppressed, patient being COVID positive and having a limited respiratory reserve. These are few conditions where the surgeon finds it difficult to go ahead and start with the surgery. So that is where it has to be together, the medical management with the surgical management. Both are of equal importance.
Right. It's like, every patient we have to, choose it, and then, suggest whether surgery is needed or not. If needed, whether he is, really fit to undergo, and with other factors, as you both rightly pointed out, associated sepsis, associated ventilatory requirement, and whether he is, really fit for surgery or not, should also be taken into consideration before designing the treatment for individual case. Thank you so much. Coming to Abhishek, how to tackle kidney injury while taking antifungal agents?
So it's a very important point, sir. So like the conventional dose of amphotericin B, the deoxyfolate format is causes injury to the kidney. So we can use a liposomal amphotericin B, the first thing. Secondly, that if we are using any other drug which is nephrotoxic, we need to take that out of the equation. Thirdly, the conventional doses that are recommended are a dose of approximately 5 to 10 milligram per kg body weight. There are a lot of centers which, not at the present time because of the unavailability of the drug, but in the pre-COVID era as well, have been using a higher doses. And so if you're using a dose of, say, approximately a 10 milligram per kg body weight and you see the kidney function deteriorating, we should bring down the dose. And very importantly, we need to pre-hydrate, give the drug, and then post-hydrate. And also, we have this habit of diluting the drug in a 5% dextrose solution and giving it to reduce the burden on the kidney. So in my practice, in my experience, these are certain tips or points which help to ameliorate the incidence of a kidney injury, which might occur by the using of a potent amphotericin B compound.
Yeah, you said, right. We have to look for, any associated, other drugs which can facilitate kidney injury, and then, presence of any hypotension or something like that, we have to correct it. And pre-hydration will also make it, renal friendly. If at all, yes, there is a huge scarcity of, antifungal agents, particularly amphotericin. If at all, if it is liposomal is available, please choose liposomal amphotericin B to conventional amphotericin B. In fact, most of the international guidelines have ruled out usage of conventional amphotericin B as a treatment of choice. So it is only recommended is liposomal amphotericin B. And with this, we'll go to the next question.
Just one
Any role of, yes, we have this. Yeah, please.
One interesting case. Everybody is aware of the shortage of antifungals. I actually have a patient who is managing on 1 day of liposomal, 1 day of conventional, 1 day of liposomal, 1 day of conventional. So these sort of settings,
fantastic.
We don't know how to answer these people. Are you doing correct? Are you doing wrong? We actually don't know what is happening.
No, really amazing. Okay, these are challenging scenarios. Okay, we have to design keeping in consideration of patient characteristics, availability of various medications. Good suggestion, Ravi Bhai. Coming to Viswesvaran, we have discussed partly this question already, but any role of empirical antifungal agents in COVID patient to prevent mucormycosis?
This is a very contentious.
There is no guideline. Yes.
Yeah,
but,
because the problem
but it
is,
always, our heart says we want to save our patient at any cost.
Yeah.
Please go ahead.
So the problem here comes is the voriconazole we start empirically is one of the major reasons for a breakthrough mucormycosis. So like
even voriconazole, as per literature, fluconazole also increase the chance of mucormycosis and all other azoles. Voriconazole, fluconazole and itraconazole.
So when you are using these azoles as a empirical treatment and you see a sudden worsening of your patient with development of new shadows, cavitations, pleural effusions, nodules or mass-like lesions, then probably that may be a breakthrough mucormycosis. So definitely empirical treatment has its own set of side effects. So there is for the CAPA guidelines, that is the COVID-associated pulmonary aspergillosis, they have given a clear algorithm on how you need to triage these patients on starting for a presumptive aspergillus infection, like you have a galactomannan positivity or you have multiple site aspergillus demonstration, then taking into the clinical consultation, clinical context, you can start a voriconazole. But an empirical therapy for a mucormycosis is definitely not advised, because the drugs what we handle for these mucormycosis, the risk will always outweigh your benefits. For example, if you start a patient on empirical amphotericin B, you are going to have a lot of burden on the kidney, which is already affected by sepsis, and you are going to deal with a lot of electrolyte problems. So definitely empirical amphotericin B for a mucormycosis is definitely not an option. And empirical azole for a aspergillosis is also not an option for preventing mucormycosis. Probably a presumptive treatment for a suspected aspergillosis with a laboratory evidence, at least a serum galactomannan or an evidence demonstration of an aspergillus in multiple sites in a repeated cultures, then probably you can consider voriconazole in a given clinical scenario.
So just one point that I want
may not be repeated cultures, at least evidence of, at multiple sites, maybe, because generally once, even if we identify invasive aspergillosis in our clinical scenario, unless we are aggressive, it will take it will lead to severe, morbidity and mortality. Yeah. Abhishek, please go ahead.
I was speaking to a couple of my colleagues from Uttar Pradesh, Lucknow, and they told me that they have this series where they're giving a prophylactic posaconazole in patients who have a higher suspect incidence of mucormycosis, may it be a dysglycemic patient or a patient on immunotherapy. And they are showing certain good results that in a way that they are being able to prevent an incidence of mucormycosis. Maybe it's just chance, or maybe the drug has some role to play. I couldn't find any literature online supporting the evidence, but certain centers are using
what happens in the current scenario is there is already severe scarcity of, antifungals. We're not supposed to, use out of, guidelines. So another important thing is even we were calculating, okay, number needed to treat to prevent one mucormycosis, probably more than 500. Okay, so this will become, very complex scenario. You have to treat 500, 600 patients to prevent one onset of mucormycosis, which is not, I think, practical. It should not be practiced, right? But thank you for your input. Do you suggest, Mayank, all moderate to severe COVID patient needs to be, even if they are not diabetic patients, needs to be under scanner of physician or diabetologist or an endocrinologist to monitor their glycemic control?
Sir, as I said, moderate to severe patients are subjected to the steroids, basically. And these patients, even though they may be non-diabetic, I have a patient who had a HbA1c of 5.2, but he had steroid responsive hyperglycemic state. For 1 to 2 days, we tried to manage him, but when we take the opinion of endocrinologist, things become better. But steroid-induced hyperglycemias are common, and many times we waste a useful first few days in managing ourselves. So we cannot be ubiquitous in managing all the things all alone. A teamwork is always good. Always take in a loop the patient who you think that they may be at the risk of, if 1 or 2 sugar levels are coming very high in those who are non-diabetic, as well as those who have history of uncontrolled diabetes or even in fact have been on insulin therapy earlier, like diabetic, uncontrolled or controlled even with on insulin. These patients may are likely to get into the hyperglycemic state, and managing a tight glycemic control is very important in these kind of patients. Many times we see sugar values of 250, 240, 300, but in a long term, if we see these patients are in a persistent hypoglycemic state, I will always recommend the patient to be taken up by the endocrinologist for the appropriate sugar control. Even in fact, insulin infusions, if they can be started early in the course, so that tight control can be maintained. My target sugar, I always take it around 140 to 180 in around, not in fact 200 or 250. I always take a little strict control for the sugar.
Right. Thank you. So always we should also, keep an eye on, causing, it should not cause hypoglycemia, which is more detrimental.
Yes.
Right. Ravi bhai, please add your inputs.
And
here.
one more thing. The good thing about endocrinologists is they just need values, basically. If they can, they can, even in the remotest areas, they can be available on telecalls also.
Absolutely. Brilliant.
So always take the help of endocrinologists.
They can manage their sugar levels alone. Okay, we can manage rest of the patient. Okay, leave the sugar part to diabetologist or endocrinologist. Dr. Ravi, please add. What is your take on this?
So my point is on this is, see, at times I agree to the vital role of endocrinologist, but what is needed is a person specifically managing sugars in the whole team, a person who is looking at the sugar part separately, apart from the physician tackling the mucor. Endocrinologist may not be maybe a luxury which everybody doesn't enjoy at times. So I would just that there should be somebody looking at it independently, not your chest physician, not your ENT person. That's what I would prefer.
So in our hospital, we have a 3-tier system, like physician, RMOs are looking at the general sugar levels. Physicians are looking at the patient, those who are at in a controlled state, but manageable state. And those patients with the risk of hyperglycemia, on the risk of having a higher value of sugar despite being on glycemics and these drugs, or even on insulin, even on a little, so we always take their opinion. So that way we can tire up the patients.
Yeah. So to conclude, what is important is, so those patients who are already diabetics, suffering from moderate to severe on corticosteroids, please make sure that early starting of infusion is very, very important in bringing up the sugar control to tight glycemic control. Probably a value definitely less than 200 is recommended, and with close monitoring avoiding the hypoglycemia. And even if you are treating the patients, okay, who are non-diabetics, young, okay, there is a huge incidence of, hyperglycemia because induced by COVID and induced by steroids in management of COVID, moderate to severe COVID pneumonia. Please make sure you don't miss, sugar control in these patients as well.
So what I say is a good diabetes control, a good sugar control can be a prophylactic antifungal in these kind of settings. No need to add antifungal. Just get a good sugar control, give steroids, but get a good sugar control.
Okay. So, Abhishek, precautions, what are the precautions we have to take while using posaconazole in cardiac patients in management of mucormycosis?
So posaconazole, like the other azoles, has this cardiac side effect of causing an elongation of the QT intervals. And especially in COVID, when we see so many other drugs like, for say, an azithromycin or a hydroxychloroquine, which also have the potential of an elongation of a QT interval. So we should actually be cautious, have a baseline ECG, and try to avoid a combination. And even in such settings, a lot of practitioners prescribe a moxifloxacin or a levofloxacin. So even the fluoroquinolone group of drugs have this QT prolongation effect. So we need to take care of two things. Firstly, that we need to avoid a combination. And secondly, we need to have a baseline ECG and then follow them up with serial ECGs at a preset defined intervals.
So you will say is, do not combine drugs which can, prolong the QT interval. And second important, identify early and then, get a baseline ECG and then track them. Okay, maybe, weekly basis or something like that so that, QT interval is not prolonged. So this question is to Viswesvaran. Role of imaging modalities in diagnosis and management of mucormycosis. How often you recommend, repeat scanning in your cases? And then subsequent question will go to Mayank, that please comment on role of PET-CT in your practice or, in current day practice. Viswesvaran, please.
So definitely in the current scenario for pulmonary mucormycosis, we rely upon the CT scan as the initial modality. And the presentation of the CT scan might vary from just an GGO, nodule, multiple nodules, mass-like lesions, cavitations, even pleural effusion, and most common what we are always thought is a reverse halo. So one aspect of this reverse halo which is different of the mucormycosis from the classical COP which we can see in the viruses, the reverse halo rim will be much thicker in case of a mucormycosis in comparison to the rim what you see in a COP which might be induced by means of your virus. But having said that, this mucormycosis sometimes can also present as an endobronchial manifestation, like just as a mucus plug, like an endobronchial mass-like lesion. That also we have seen. So that is also a presentation. For example, if you are having a normal CT scan, but still the patient is having a hemopsis or an endotracheal bleed, then probably you might be still harboring an endobronchial variant of a mucormycosis. And with respect to the orbitorhinocerebral, which we commonly seen, CTPNS gives us the first clinch to the diagnosis. Whenever you are seeing a sinus extensively filled and you have a clinical background, then you need to suspect given in the current scenario. And apart from that, the other things what you can identify in the sinus is the invasion of the orbital planes, like when it is extending beyond the orbital planes into the brain, because that can give you some idea whether he is a perfect candidate for a surgical resection or not. For example, if there is an extensive brain invasion, then probably your local debridement is not going to add anything except for your satisfaction that you have debrided the mucor. So these are the primary imaging modalities which we have to use. Apart from that, there are cases of even renal mucormycosis that are seen. And even if you have an unexplained hematemesis, then probably these mucormycosis might be even in your gut. So that requires a special warranted site-focused imaging modalities. So basic CT scan and a CTPNS in a high clinical suspicion of mucormycosis are the bare essential modalities to diagnose it.
Yeah, I was reading some literature, Viswesvaran. There is a point that involvement of pterygopalatine fossa or involvement of mucous membrane is early identified in the MRI of orbit and sinus with contrast enhancement. Okay, that is the earliest sign that people say as per the imaging modalities. Probably when the facilities are available, it is wise to order for MRI as well to identify early invasive fungal detection. Yes, Dr. Murali Mohan wants to add something here.
Just a word of caution: don't rely too much on the imaging modalities. We recently had a patient unexplained headache post-COVID, and the CT PNS was normal. An MRI was normal, nasolaryngoscopy and a sinuscopy was normal initially. Only the nasal endoscopy was normal initially. We investigated for every cause of headache. And then finally came back, and I think almost 2 weeks later did one more MRI. This was the third imaging. And this picked up thickening of those, of the sinuses, showed for the first time something within the sinus, and slight, the contrast enhancement of the plates. So that's when we went in, did an invasive sinuscopy, took a biopsy, and that showed evidence of mucormycosis. So again, as everybody has been emphasizing, clinical suspicion is very strong. Be a little more aggressive in your initial approach, because as you rightly said, you have to hit it early, you have to hit it hard. This gentleman is still undergoing treatment. He's 76. And I'm really worried about him because, they respond very poorly to treat, not very poorly, but definitely the treatment responses are much less good. So don't rely only completely on the imaging to rule out mucormycosis.
Thank you, sir. Thank you. And Mayank, your point on, do you suggest, PET CT? Probably, I think, maybe as a...
So it's a far big shot. If my patient is in acute emergency, I would rather take up
acute, for definitely no. There is no to PET CT
no role of PET CT in acute scenario. So even in the chronic scenario,
where when you want to stop the treatment.
So first of series of debridement is there, and if we want to be very sure that no debridement is needed further ahead in the long term state, then we can plan earlier. There are some literatures also saying about PET CT, but utility in COVID scenario, it's still a question mark. I would not recommend getting the PET CT done for the patients. It would be a wastage of resources as well as not advisable.
Right. Thank you. And is there any role of
soon after a debridement, you're very likely to have increased uptake in those areas.
Yeah.
Okay, so it doesn't help you in the immediate situation also until the healing has occurred.
Probably what I believe is probably when you are treating a nodule or something in the lung or which is resolving, you want to take a chance that, at what time you have to stop the therapy. Probably that's what, if the serial scan shows, there is no uptake or very little uptake, then probably you can think that, yes, the nodule is completely devoid of mucor or any inflammatory activity, and then you can take a call on that. You can stop the antifungal therapy.
You're still not sure, you still have to monitor carefully.
And still we have to get the cultures done for the same, because if presence of fungal hyphae can also cause a relapse of infection.
Yeah. And this question goes to Dr. Ravi Dosi. Is there any role of methylene blue in Mucor?
Well, sir, actually, it's a very difficult question because somehow
that's why we are asking you, man.
So there is a big romance in between methylene blue and this COVID-19 epidemic.
Yeah.
People will impose it on you even if you don't offer it to them. So I won't say yes, I can't say no, because we use it. If you don't use it, next day morning when you go to the rounds, you find that the oxygen flow meters have automatically turned blue. The attenders nowadays over there. So somehow I haven't seen a patient whom I have managed without methylene blue up till now. Despite that, I have seen mucor in a lot of my patients. So I won't say that methylene blue has a prohibitive effect on mucor. The level of concentrations that a few people post on the WhatsApp of methylene blue to use, in which you turn really ugly blue. I will never use that concentration of methylene. Sublingual or IV. Again, I haven't used sublingual or IV. Nebulized is the only way I have used, more on demand rather than per se, but have not found a prohibitory role. What methylene blue is, it is antifibrinolytic, it is mucolytic, it is decongestant. To the maximum has some role in mild COVID, although how it will break the thick mucus of COVID still remains a mystery to me. The proposed mechanism of action is the oxidative role that it plays, and it has some role in ferritin and zinc metabolism. But again,
But
practically speaking, I don't know how much of a
as
role
the
it has.
conclusion point, there is no role of methylene blue
Methylene.
either as a therapeutic or as a prophylactic agent. Right?
None whatsoever.
And the next question goes to Viswesvaran. Is there any role of statins in preventing Mucor?
Uh,
I have seen a couple of articles stating that it can.
There are various articles actually, both in vitro studies and in vivo studies, especially of combination of statins with amphotericin B. So they have found that the combination arm had much higher chance of a fungal clearance in comparison to amphotericin B alone. In fact, they have compared amphotericin B with atorvastatin versus amphotericin with another statin, which I forgot, rosuvastatin, I think.
Rosuvastatin.
Yeah. So they found out that amphotericin with atorva was found to be more beneficial than the other statins. And one more thing, recently, there are also few debates about the role of statins in treatment of COVID as well. Like they say it has got an anti-inflammatory property. Having said that, statin has been tried in almost all sort of inflammatory phenomena, even for that matter, sepsis, but we still do not have enough guidelines on the exact role of statins. Since it is a very harmless drug and you have evidence, though not a randomized controlled study, you have clinical evidence of an improved efficacy both in vitro and in vivo. There is no harm in starting an amphotericin B with an atorvastatin if you have an access to it. So it can be used. And there is not much
as per you say, you can use as a additive agent, but there is no scientific or evidence so far.
We don't have a strong evidence. There are evidence of both in vitro and in vivo studies.
Right. So how and when to step down from amphotericin B to posaconazole or isoconazole oral, and what duration of treatment you advise for mucormycosis? Again goes to Viswesvaran.
So again, this is a contentious thing because there are no head-to-head studies to say that this is the exact point duration where you are going to shift. Having said that, your induction, just like we have an induction and continuation, similar to that, we are going to have an IV phase of amphotericin B. This generally lasts between 3 to 6 weeks, depending upon your clinical resolution of the symptoms, as well as you need serial imaging modality to see whether there is a reduction in the cavity or whatever the nodule or the mass which you are seeing. So after 3 to 6 weeks, if you really have a significant clinical improvement as well as a radiological resolution, then you can shift these patients from to the step-down therapy, either in the form of a posaconazole or isoconazole. If you are going to use a posaconazole, it comes as IV formulation, it comes as delayed release tablets, it comes as suspension as well. If you are using it as a delayed release tablet or an IV, you give 300 milligram twice daily on day 1, followed by 300 milligram OD. But if you are using it in the form of a suspension, then you give 200 milligram 4 times a day or 400 milligram 2 times a day. And if you are using isoconazole, you start with 200 milligram 3 times a day for first 2 days, followed by 200 milligram once daily. And the duration of these treatment, also there is no consensus. You need to continue as long as you have a significant clinical resolution as well as a radiological improvement. And this normally extends from most of the experience of the ENT somewhere between 2 to 3 months, at least the bare minimum. We continue these drugs, and it may be extended even beyond that when you feel that the lesions are not subsiding. So And in addition to this, they have tried a combination therapy in the induction arm, like you add a posaconazole to an amphotericin B, but they didn't found any significant improvement in comparison to amphotericin B alone.
But some studies have revealed that posaconazole addition will, facilitate early, a decreasing duration of therapy overall in the induction phase. That's what.
Yeah, there are few studies, sir, but overall, the consensus remains like we don't have enough evidence to say that always you prefer a combination arm with an amphotericin and a posaconazole. It is used more like a.
We are facing huge crisis of lack of liposomal amphotericin B. Probably we may need to add if we are using conventional amphotericin B, we can add posaconazole at least.
Yeah, you can use it as a salvage. Like we can consider it as a salvage situation, and we can maybe because of the current non-availability.
So, before passing on this question to Dr. Murali Mohan sir, okay, there's an interesting announcement. There are so far 1,260 logins, which is a really huge. Okay, thank you, CCA, thank you, Krishnana. So, Murali sir, your take on on how to step down, on how long you give treatment in these cases. You want to add anything here?
No, absolutely not. I think Dr. Viswesvaran has covered it very clearly. It's very, very important not to have a fixed time and say, I will give it for this much time, I will finish this much of amphotericin and then stop it. We recently had a patient who seemed to have remarkably improved, reach what was planned, and come back 2 weeks later, despite being on posaconazole with a recurrence. So, I mean, I think amphotericin, whether it's liposomal or the deoxycholate, whichever it is, you have to use it. You have to use it continuously as long as the patient can tolerate it, till you're very satisfied with clinical and radiological resolution. And after withdrawing it, put the person on posaconazole, whatever time that takes, whether it's 3 weeks or 6 weeks or 3 months. And then only you have to, after that, you still have to monitor very carefully because recurrence is a big problem. And at the same time, we need to make sure that the diabetes that very often is there is kept under tight control throughout this phase.
Thank you, sir. Besides, time and the immunomodulation, whatever the drugs we are using, and then other conditions like uncontrolled diabetes have to be strictly, monitored, and then sugars have to be controlled strictly so that to prevent the recurrence of the disease. And coming to dosage of various formulations in mucormycosis, what are the various tests you need to monitor and how frequently you monitor? This is for audience sake. We have discussed in bits and pieces. I want, Dr. Murali Mohan sir, your take on liposomal amphotericin B first.
So liposomal amphotericin B, the standard dose is 5 milligrams per kg. In CNS, they have used 10 milligrams per kg without much evidence that it is better than 5 mg per kg. You run the risk of higher renal toxicity, perhaps without getting that much additional benefit, but it's still one of the dosages that is tried. When we initially used to use liposomal amphotericin, we used to hike the dose gradually. It's permissible to give a test dose and then carry on, but I think right now we've switched to using full doses right from the beginning. So we don't start with a gradually escalating dose. I think it's important to get it under control quickly, important to get as much dose as you can. So we start with 5 mg per kg and we continue that now we're not able to get liposomal. I think the whole country, we're having great difficulty. So we are now, I don't know how well it works, but we are getting the lyophilized form with the lipid. We sometimes mix it with intralipid. It reduces the local adverse effects, but doesn't seem to make any difference when it comes to renal toxicity. And of course, the standard formulation, we use a dose of 1 to 1.5 mg per kg. You have to monitor all these carefully, whether it is liposomal or not. You can't get away from the need to monitor regularly. And of course,
apart from renal, what else you will monitor, sir?
Sorry, you have to pre-medicate if possible. Give them saline before, saline after, if the patient can tolerate it. Typically, we get about 500 ml to a liter of saline along with this to help reduce the renal toxicity. Some reports that you can use, I don't really know if there is strong evidence, but you can use sodium bicarbonate along with it. But the monitoring, we monitor obviously the renal function and the potassium very carefully.
Right. And if potassium is not getting corrected, we have to look at the magnesium.
Magnesium also.
Standard of care, right. And Viswesvaran, you want to add anything, to this when we are giving conventional amphotericin B?
Main thing is the dosing. Like we give 5 milligram per kilogram with the liposomal. Here the dosing is 0.3 to 1.5. So for a pulmonary aspergillus, pulmonary mucormycosis, we range around 1 milligram per kilogram body weight of amphotericin B deoxycholate. And the other problem with the conventional amphotericin B is there is a higher risk of developing nephrotoxicity in comparison to the liposomal. So as sir said, you need to hydrate them with saline like at least a liter prior to initiation and 1 liter following the amphotericin B if it is you don't cause a fluid overload and pulmonary edema. And the other thing is most of the conventional are at a higher risk of developing anaphylactic reactions. So what they do is they just take a 1 milligram of amphotericin B and dilute it in almost, as you said it in your slide, around 25 to 100 ml of 5% dextrose, and you give it over 30 to 60 minutes. And you see if the patient develops any anaphylaxis reactions or not. And prior to initiation of this amphotericin B, you need to give NSAIDs or acetaminophen, or in few cases, you might even have to give some acetaminophen and steroid combination. But generally for mucormycosis, we tend to avoid these steroids. And in case if your patient develops any sort of an anaphylactic-like reaction, the drug of choice is meperidine to control this anaphylactic-like reaction. And
we lost you.
Can you hear me, sir?
Yes.
Yeah, please.
So the next thing is with respect to the conventional.
What is the drug of choice you were saying? Viswesvaran?
Yeah, meperidine. Meperidine is the drug of choice. And the problem with the conventional amphotericin B is you cannot go straight ahead and say that I'm going to give the full dose because we know that anaphylaxis is a problem. So what we do is we start with roughly around 30% of the required dose and we give it and we stop. We give it over 6 to 8 hours actually. And then we stop and we look for any anaphylaxis or not. If it is not there, then next day you escalate it to further higher dose, but at least within 3 days, try to reach the weight targeted dose, because the more and more you are going to suboptimally dose these patients, then higher is the chance of progression. So within 3 days, you should reach the desired target. Let's say 1 milligram per kilogram and the patient is 50 kilograms, you need to reach that 50 milligram per kilogram within 3 days. So these are the few caveats with respect to the conventional amphotericin B.
Thank you. Ravi Bhai, so your take on, dosage, administration, and you monitor any particular things when you are administering posaconazole?
Mostly available in 3 forms: suspension, oral tablets, and intravenous form. Posaconazole primarily you use intravenous more than 18 years of age. In case of mucormycosis, 300 milligram twice daily on day 1, followed by 300 milligram once daily, be it in tablet or IV form. Suspension would be 200 milligram twice daily, followed by 200 milligram once daily. The duration goes on to 2 to 3 weeks or till clinical or till an acceptable point of stopping it. The monitoring was, as told by Abhishek earlier, in the form of ECG and QT intervals. They have to be monitored regularly.
And sometimes liver functions, as it belongs to, azole group. Mayank,
Yes.
add your, views on isoconazole.
Sir, first of all, I would like to add on the dosage, if you're using liposomal amphotericin B or like in a CNS involvement, dose can be a little higher, like up to 10 mg per kg. And second thing about the isoconazole.
In CNS involvement, just for, addition of this point, there have been case studies and then, reports where 15 mg per kg body weight have been also administered using liposomal amphotericin B.
Yes.
Yeah.
So it also if the disease you think is progressive, the new lesions are appearing despite patient being on amphotericin B, we can add or combine with either posaconazole or acevuconazole combination. Like you have said, the utility of combining and these antifungal, we can there's still data that is lacking, but still if the patient is still progressing on the conventional therapy, we can combine the antifungals. Second thing is about the isobuconazole, as we the dosage has been for 2 days 200 mg TDS, then 200 mg OD from day 3 onwards, can be used in a as a step down therapy also, but still patient has to be very gradually monitored for the new lesion. And I would suggest the stoppage of therapy only when my scrapings are coming negative for this Mucor, and there is no active or new lesion present, and my radiological parameters are also in control, then only I can plan, and still I have to monitor for around weeks to the patient.
Sir, to Abhishek, is there any role of giving intralesional amphotericin B, something like intraocular or intralesional into the sinus? Okay, what is your take on it?
Sir, conventionally, intraocular injections of liposomal amphotericin B have been used in the vitreal cavity for fungal endophthalmitis, or even in the aqueous humor for corneal keratitis. And so in that setting with Mucor, I guess it should be safe to use. And I, like all of us, I was reviewing literature and I saw a lot of case reports where amphotericin B has been instilled intracavitary into a lung cavity, or per se into transtracheally into the bronchial lumen, or even into the pleural space where a pleural effusion of a Mucor origin was found. So these are anecdotal case reports, but the data was encouraging. Obviously, RCTs are lacking, but depending upon seeing how rare Mucor is per se, we can pick up from these anecdotal case reports, and in the appropriate setting, I guess we could go for certain therapies like that.
Thank you. So, Murali sir, would you like to add a comment on this, sir? Intralesional into your muted, sir, please, sir. Unmute yourself, sir.
No, I think Dr. Abhishek has covered everything that needed to be said. Really nothing to add.
Thank you. There's a huge questions that are still pending, but as the time is now 9:50, okay, I don't. So let me take one last question, and then we will. There are multiple people have said that it's excellent, speechless, spellbound, so many things. They have adjectives I have added. They have appreciated our efforts. One interesting thing, sir. Now, what about the usage of industrial oxygen cause behind mucormycosis? Last question. Please, sir. Any?
I honestly don't think there is any connection. Needs to be investigated, of course, like every suggestion has to be investigated. But I understand from, a neighbor of mine who was the vice chairman of Tata Steel, the quality of industrial oxygen produced is better than the quality of medical oxygen. That's what he tells me. So
okay.
I don't honestly think that is a big issue. It's not like it's some dirty oxygen that is coming from the industries. It is pure. Right. It is probably purer than the medical grade oxygen. So there's no reason to suspect it. However, I think it's important that we check it out because it's one of the things that has changed between the pre-COVID era and the COVID era. And that too, only in the second wave, we are starting to use industrial oxygen. We didn't have this problem in the first wave. That itself, I think, will tell you that it's not a likely cause and doesn't contribute much. But, I'm open to learning more on this.
Right. So, on the other hand, it has been proven also these humidifiers were attributed to increased, addition of
Tap water.
what do you call untidy humidifiers. Okay, maybe the result of mucormycosis. That also it has not been proven so far as a really causative agent for increased incidence of mucormycosis.
So in this second wave, what has happened? The home oxygen usage is also increased, and the problem with the humidifier, they're putting all the tap waters not cleaned properly, and I've also experienced the patient who have been long stayed at home and received oxygen, and these are people who are more into these. This is my personal observation. I don't know about needs more matter of investigation. But yes, one thing can be a inappropriate handling of humidifier at home and at the hospital.
Right.
I'd just like to emphasize that, we've used this term several times. Mucor is ubiquitous. We don't need a special thing to give us mucor. Okay, it's what's happening inside our bodies, a response to this, because it's just everywhere.
So, there are signs coming from cipla team that they want to go for dinner. Okay, even we want to wind up and then wrap it up. So thank you, one and all. Thank you. First of all, let me appreciate the brilliant thought process from Krishna Anna, our founder, chairman, trustee, who is working relentlessly to create series of webinars for the benefit of. So for the benefit of our Indian pulmonologists and then physicians as well. And I thank one and all here. Murali sir, really, thank you so much for your presence, mattered most here. Okay, you are like big brother to CCA and then Indian pulmonology. Okay, you have guided us, very well. Thank you. Thank you, Viswesvaran, for, taking part in your, busy schedule and then, joining us. Thank you, Mayank. Thank you, Ravi Bhai. And thank you, Abhishek. You did wonderful. I know this is your first webinar, but you did phenomenal. And thank you, our core technical team. Okay, our Vinod, Vipul, Cipla team, others. Okay, fantastic job as usual. Thank you so much. Signing off. Looking forward to meet in the next webinar next week on Thursday. Guruvar ke raat, Guru ke saath. Thank you.
Can I just say thank you, Dr. Vijay Kumar Chennamchetty, for that excellent lecture in the beginning. And of course, I've learned so much from, all of you, Dr. Viswesvaran, Dr. Mayank, Dr. Abhishek. As I said in the beginning, I tend to learn much more from these meetings than I contribute. So thank you all very much.
So only apologies, I have not asked, a few questions from many of audiences because of lack of time only. Thank you, delegates, for joining this across the country. Almost 1,200 plus have joined. Thank you. Definitely, we will, clarify. I think I have filtered your questions such that I have covered almost every topic in today's webinar. Thank you so much. Signing off. Love you all.
Thank you.